Good afternoon, good evening, and good night to everyone. Welcome to the second IFSO APC webinar. And actually, this is our very first IFSO APC Integrated Health webinar. So I'm very happy to have people all over the world. I've heard people really around the globe has joined us. And I'm also very happy to have on our panelists, people from Australia, someone special from Australia, some from India. And my name is Dr. Quang Wei Pham. I'm from Singapore. I'm actually the Vice Chair of the Integrated Health Committee of the IFSO APC. I'm also a Secretary of the Asia-Oceania Congress of Obesity, and I'm actually an endocrinologist by training and practice at the Singapore General Hospital. And it gives me great honor and also great pleasure and excitement to host and to be the moderator of this meeting. I would like to introduce our speaker, is Ms. Caroline Remedios. Caroline is actually a team leader in nutrition and patient services at Dr. Murphy's Digestive Health Institute. And she is actually an accredited practicing dietitian. And she has actually a master's in dietetics from Deakin University in Melbourne, Australia, and also a specialist in sports nutrition. Caroline actually has had a wealth of experience practicing with Dr. Murphy in the area of bariatric surgery, and she's actually published quite a number of papers in this area, and she's going to enlighten us on the topic as we've published. With me is also a panelist, Ms. Stephanie Gilroy. Stephanie is an accredited practicing dietitian and nutritionist at the St. George Private Hospital in Sydney, Australia, as well as the Macquarie GI University Clinic. And she's also an honorary clinical lecturer at the Macquarie University in New South Wales, Australia. So please welcome the two of them with me tonight. Tonight's topic is actually very, very relevant, and often we take nutrition as a part of bariatric surgery, part of bariatric medicine, but truly how important it is, be it pre-op or post-op. And we ourselves come from different parts of the world, different parts of Asia even, and different parts of Asia with different diets, different cultures, and how is that really going to affect the nutrition of our patients? So I think today we're really fortunate to have Caroline to enlighten us on that. But before we start, we're actually going to do a quick poll. All of you will be able to poll on this question, and when the question is posted, you have about 10 to 20 seconds, and please interact with us and let us know your thoughts. We're going to start the poll right now before we start the talk proper. So the first question is pre-op assessment by a nutritionist or dietitian, should that be mandatory? Yes or no? All right. I think we're still collecting responses here, sorry. About 17% more of people. All right. So good majority of you feel that we need a pre-op assessment. Caroline and Stephanie, you definitely have a job to keep for a long time to come. Let's move on to our very next question, our next poll, which would be, should nutritionists and dietitians counseling patients for bariatric surgery undergo specialized training in bariatric nutrition? Strongly disagree or disagree? Oh, sorry, it should be strongly agree. Actually, that's series of 5. Just poll your thoughts there. All right. Okay, I think most of you do agree that we should have nutritionists undergo some serious training before they counsel patients. Let's move on to our next poll. Pre-op assessment by nutritionists should be, oh, sorry. Do you believe that there should be country or culture-specific nutritional guidelines for bariatric surgery? All right, I think there's a little of mixed feelings here, though about maybe 70% of people feel that there should be some specific nutritional guidelines. And then the next question there. Pre-op assessment by, sorry, I subscribe to the following guidelines in my nutritional supplemental practice. Please pick one of the answers. All right, that's good. I see that quite a number of people have their own countries and local guidelines, which is very helpful. If not, most people prescribe to ASMBS and ASPEN guidelines. All right. Thank you for your participation in the poll. We're actually going to start the talk proper. And to share with us will be Caroline Remedios on the importance of bariatric nutrition and the current worldwide guidelines. Caroline, thank you.
Thank you so much, Wang Wei, and welcome to our first Integrated Health IFSO APC Integrated Health webinar. And it's very exciting that we've chosen bariatric nutrition because it's very close to my heart. So just to sort of understand whether we actually need guidelines, and do we actually need a multidisciplinary team? Just give me 1 second. I don't think my slide is moving here, but just give me 1 second. It's sympathy isn't moving. Okay. All right. Sorry there, guys. We just had a little bit of a technical hitch. But just to sort of understand whether a multidisciplinary approach is actually needed for the care of a bariatric surgical patient. And if you can see on your screen there are a lot of societies globally that actually think that a multidisciplinary team approach is actually very vital to the care of a bariatric surgical patient. So who exactly should be involved in the care of a bariatric patient? Other than the surgeon, obviously, we definitely need nutrition expertise. We need an endocrinologist on our team. We need a psychologist, and in addition to a physician and to nursing to actually be able to give the best care to our patients. Knowing that we have multiple types of surgery that are being done all over the world, and also some surgeries which are very region-specific, surgeries that are specific to specific clinics, it is important to understand where the nutritionist actually needs to be competent. So these are just a few pointers in terms of what is needed from a nutritionist to be able to give the best care to our patients. So number one is actual understanding of the different types of bariatric surgery, surgeries that are done in your specific part of the region, and surgeries that are done across the world as well. Very, very important also is to understand that you need to have a proper pre-assessment of your patient. You need to understand your patient thoroughly. You need to understand his likes, his dislikes, his eating patterns to be able to counsel him pre-operatively and post-operatively. The other most important thing is actual knowledge of which surgery will cause which nutrient deficiency to be able to actually supplement your patient accordingly. And of course, something which is extremely vital are what kind of medical emergencies that can be prevented by a nutritionist. And to name a few would be B1 deficiency, which can actually cause irreversible damage like wernicke's encephalopathy, protein energy malnutrition, which could be very common, hypoglycemia, and liver failure. So in what sort of situations do we actually need a nutritionist? And I believe that we need a nutritionist right from the preoperative stage, right up to long-term situations. And we go through each one of these situations in my next slide. As bariatric nutritionists and those who are practicing bariatric nutrition, preoperative diet is a standard protocol, and we all are doing this in our day-to-day practice. And there's a lot of literature on this. But also what's more important to understand when we are actually prescribing a preoperative diet is to understand that our patients do not come in only with obesity, but they come in with a myriad of problems. And it is important to be able to modify our preoperative diet to suit the need of the patient. So a few examples as to where we need to modify a preoperative diet is our patients that are insulin dependent. So in order to be able to prevent hypoglycemia, we need to make sure that they're having their meals frequently, that we have an endocrinologist on board who is able to monitor and adjust their insulin dosage. You will have patients who have high uric acid levels, and in that sense, we need to make sure that we're low in purine content, to limit the sources of non-vegetarian proteins, and to also make sure that they're hydrated well enough with water. Liver disease is another biggie. You'll have patients who will come in with compromised liver function, and the key here is to make sure to avoid severe protein restriction and to calculate their protein requirements accordingly. You might also need to adjust their sodium and their fluid in case of ascites or hypernatremia. Renal disease is another problem that you will face preoperatively. Here it is important to make sure we give our patients high biological value protein. You might need to adjust their potassium, their sodium to make sure that the electrolytes are not haywire. And in conjunction with the nephrologist on the team, you might also need fluid restriction sometimes. And there will be cases when you might have patients with cardiac disease, and there could be occasions where you might need to adjust fluid and sodium in that case as well. So it's always important to keep in mind these few instances where you might need to adjust your preoperative diet. The other situations that we come across fairly routinely in the immediate post-operative phase are things like nausea and vomiting, constipation, acidity, bloating, flatulence, excessive gas. These are common things that most of your patients will come back with, and most of them can actually be managed with just simple education to the patient in terms of chewing their well, eating slowly, sipping enough of water throughout the day, making sure that there's not too long of gaps in between their meals, and also simple things like avoiding straws, avoiding chewing gum to sort of reduce intake of gas. So these are simple things where a nutritionist can actually make a difference to ease that transition of your patient. However, amongst all of these situations, there is one situation that is not normal, and that would be in case your patient comes in with persistent vomiting. I'd like to just stress a little bit upon this slide because in case of persistent vomiting, you need to remember that it could lead to thiamine deficiency, and that could lead into irreversible damage if not corrected immediately. So if you do have a patient that comes back to you with persistent vomiting, it is imperative that you supplement them with thiamine injections, either intravenously or intramuscularly, immediately, even in the absence of lab reports, because it is important that you do not reach a point where it will be difficult to get back your patient from neural damage or damages where they're unable to walk on their own, or even severe damages, irreversible damages like the wernicke's encephalopathy. Important in this case to also remember is that thiamine is stored in very small amounts in your body, so which will require constant replenishment. And that is why it would be a good practice to actually supplement your patient with a B complex supplementation for the first month of their surgery to avoid situations like thiamine deficiency. Also important that if your patient does come back to you in case of dehydration, a common practice is to actually give them an IV infusion, but it is also imperative to make sure that you actually have B complex vitamin added into this infusion, again, to prevent thiamine deficiency. Dumping syndrome and hypoglycemia. Again, I've sort of clubbed this in one slide because most of your late dumping syndrome will actually cause hypoglycemia. And hypoglycemia can be actually very, very distressful to a bariatric patient. It adversely affects the patient's quality of life. And if it goes undetected or untreated, can actually cause, again, irreversible damages. In case your patient's blood sugar drops down too low, it could cause a lot of neuroglycopenic changes, which we don't want. So I think when it comes to hypoglycemia, it is important for us as nutritionists to be able to recognize the symptoms of hypoglycemia, recognize what habits of your patients are actually causing these symptoms, and to then treat it accordingly. Also important that you will probably need the input of your endocrinologist in this case, in case nutritional intervention doesn't solve this problem. However, just to take you through what you can do in terms of nutritional management if your patient does come back with hypoglycemia. So the important things to remember is to be able to understand how to treat the low blood sugars promptly. Important also to prevent over-treatment of hypoglycemia, which could then cause rebound hyperglycemia. Then again, it is important to educate your patients to prevent future episodes of hypoglycemia, and also to be able to treat them so that we don't cause weight regain in the long term by constantly treating hypoglycemia with simple sugars. So what do we do then? First, we need to educate our patients about hypoglycemia and dumping syndrome. We need to educate them on complex carbohydrate meals, explain to them the kind of meals that they need to be incorporating in their daily diet, a mix of complex carbohydrate meals with optimal protein intake. You can also use fiber supplements in this case to be able to manage their blood sugars. Educate patients to avoid refined foods, sugary drinks, and alcohol. And also something which might go unnoticed but could play an important role to prevent hypoglycemia is actually avoiding drinking fluids immediately post a meal. However, if all else fails and nutritional intervention doesn't sort of stabilize your patient's blood sugar levels, it is important to recognize that it is now time to refer this patient to our endocrinologist, who can then prescribe certain drugs to be able to manage their blood sugar levels. I know that the prescribing of these drugs are actually the work of an endocrinologist, but we as nutritionists should know what kind of drugs are available. And I would sort of urge you all to read up about a drug called acarbose, which is commonly prescribed to be able to manage hypoglycemia in post-bariatric patients as well. Now coming to the state of deficiencies and nutritional deficiencies. When we do see an obese person, I think the first thought that comes to their mind is that the patient is probably overnourished. However, for those of us that have been working with bariatric patients, we do understand that these obese individuals actually have a very high incidence of nutritional deficiencies, and they actually come in with severe malnutrition. Now, what are the causes of these nutritional deficiencies in our obese population? The causes are multiple. It is poor food choices, long-term side effects of medications, their sedentary lifestyles, and also their chronic dieting that they've been going through can cause multiple deficiencies in this set of patients. These are the 5 most commonly seen nutritional deficiencies in our obese population, and those of you working with bariatric nutrition will commonly see them in your patients as well. Now, these deficiencies can be exaggerated post-bariatric surgery for a multiple of reasons. And I've listed down the most common ones here. The most common ones are, first and foremost, a reduced intake of food because of small pouch sizes. There will be a reduction in gastric acid and intrinsic factor in both restrictive and malabsorptive procedures. Procedures that bypass the duodenum and parts of the jejunum will also cause malnutrition of those certain nutrients, delayed mixing of pancreatic juices and gastric juices. And of course, probably the most common things are food aversions and intolerances that most of our patients face in the immediate post-op phase. And sometimes these intolerances also last in the long term as well. Now, if I were to go through each of the nutrients, the couple slides that follow will actually show us which nutrient is deficient and for what reason. So first, coming to iron, because of the lack of gastric acid post-bariatric surgery because of the resection of the stomach, you will have a reduction in the conversion of your iron to the most absorbable state. Procedures where we actually bypass parts of the intestine will also cause a malabsorption of iron, and of course the increased gastric emptying and delayed intestinal transit time. Vitamin B12 again is very commonly seen because of the reduction in gastric acid, which sort of hinders the release of the bound form of vitamin B12 from food. There's also the fact of the reduction of the intrinsic factor because of the resection of the stomach. And also bypassing of majority of the stomach and some part of the intestine will also exacerbate vitamin B12 deficiency. Calcium again will be caused because of reduced gastric acid production and also bypass of your most active absorption sites, which are your first part of your intestine, like the duodenum. Vitamin D3 deficiency will be caused in procedures that bypass the jejunum and the ileum. Vitamin D3 deficiency is also caused because of delayed mixing of bile juices and also reduction absorption area. Protein is another big nutrient. Though we know that protein is absorbed in almost the entire GI tract, it can be of a problem, especially in your immediate post-op phase because of your reduction in the food intake, because your patients come with multiple food aversions and food intolerances, and most of these aversions and intolerances tend to be towards protein-rich food. Sometimes that could cause protein deficiency. And in procedures that basically bypass a lot of your intestine, like your SRDS, your BPD, and your duodenal switch, you will have protein deficiency as a major problem on your hands when dealing with these kinds of procedures. Folic acid, again, like vitamin B1, is in very small amounts in the body, and it will require constant replenishment. Deficiencies could occur again because of the reduction in food intake, and also when you're bypassing, parts of the intestine where your folic acid is actually absorbed, which is in case of your malabsorptive procedures. Fat-soluble nutrients and trace elements, again, these are more pronounced in procedures that actually bypass lengths of the intestine. So again, procedures like your SARDI, your BPD and DS, these trace elements and fat-soluble nutrients will be more pronounced in these procedures. Like we've seen in the past few slides, it is important as a nutritionist to understand what surgical procedure is actually going to cause what kind of deficiency, and also very important to recognize the symptoms of these deficiencies to be able to replenish and replace these vitamins. And replacement of vitamins and minerals is extremely critical for the success of bariatric surgery. And for those of us who are sort of just starting off into bariatric nutrition or are not sort of sure how to supplement our patients, there are multiple guidelines that have already been published world over. I think the most reviewed one is probably the ASMBS guidelines, which was published in 2008. Most of us have sort of gone through these guidelines of actually supplement our patients because of the depth in which the authors have actually helped us with sort of picking out each nutrient and giving us the actual supplementation dose. Again, there have been guidelines that have been published by the International Diabetes Federation, which also sort of gives us in terms of how to manage these patients. So we have guidelines that have been published by the European Society. We have the British Obesity Metabolic Surgery Society, which has also adapted these guidelines to suit their set of population. And of course, we also have the guidelines that have come out from Asia, which is the Bariatric Nutrition Guidelines for the Indian population, which was published in 2016. So these guidelines sort of help us nutritionists to be able to manage our patients according to the deficiencies. And just to give you a snapshot of what is available out there, so you guys can actually download it and actually see it and use them in your practice. The ASMBS guidelines published in 2008 actually goes by per procedure and actually helps you pick out which surgery would require what supplementation and in what dosage. Very specific to each procedure, they talk about fat-soluble vitamins, trace elements, and everything that you would require for the care of your patient. The IDF statement also sort of lists down procedures that entail your gastric banding, your sleeves, your Roux-en-Y gastric bypasses, and your malabsorptive procedures. It also helps you to sort of decide what nutrient would actually require additional supplementation in which type of procedure. Then, of course, you have the guideline that has been published by the American Association of Clinical Endocrinologists and the ACMBS, which also sort of goes per surgery-wise. This is just a snapshot of the routine nutrient supplementation that has been prescribed post-bariatric surgery. And of course, you have the guidelines that were published by the European chapter of IFSO, which specifically entails supplementation for procedures like the like the BPD, which actually talks about the actual dosage of your fat-soluble vitamins and calcium, specifically for malabsorptive procedures. Then again, like we spoke about, the British Society has actually adapted a lot of these guidelines and specifically mentioned names of supplementation and multivitamins that that can be bought over the counter. So these were adapted from the ASMBS and the European guidelines to suit their population. However, when we're coming closer to home and coming closer to our region, we need to understand that our diet patterns, specifically for our population in Asia, is probably very, very different from the Europeans and from the Americans. So I've just sort of given a snapshot of a few of the cuisines that are available in Asia, and it is probably an oversimplified version of the diet. But just to bring to your notice that the staple foods are actually very different to what we would find in other parts of the world. So if you go through the Chinese cuisine, for example, the staple is actually rice and noodles, which are either made from wheat or rice or steamed buns. They have a lot of vegetables and fish and meat in their diet, but the staple actually is rice. Similarly, with the Japanese cuisine, staple again is rice. They eat do eat a lot of fish and seafood because of their proximity to the sea. But again, going down here, the staple food is rice to begin with. Coming to the Indian cuisine again, major part of our meal surrounds wheat, rice, and millets. We do have a lot of pulses that we sort of include in our diet, a lot of variety of vegetables, and meat in most parts of the country is optional because primarily most of our population is actually vegetarian. And across the entire country of India, you actually have different parts of the country that have very, very different sort of eating patterns, different kind of foods that they eat. Most of these sort of foods that are eaten across the country are specific in terms of taste, in the kind of cereals that are used. So it's very sort of diverse across one country itself. So the point that I'm actually trying to bring across is that different countries and different regions will actually have different cultural eating patterns, different foods that they're eating. So deficiencies will also differ depending on the eating pattern. So coming again back to the Indian deficiencies, and these are the deficiency rates of Indian population that are just the general population. So we already have a very, very high deficiencies of iron, B12, D3, calcium, and protein in our general population. So when we come to the obese population again, these deficiencies are again showcased because of the sort of obese condition of our patients. So we have a general population that is already extremely deficient in these nutrients, and then we have obesity sort of that exacerbates this condition. And the cause of these deficiencies are actually primarily because of the kind of diet that is eaten in our country. So if you look at the per nutrient reason, we actually see that even though we eat a lot of iron-rich foods, we're actually consuming the non-heme iron, which is actually less absorbable in our system. Most of our diets are vegetarian. We have a high intake of tea and coffee, but also hinders iron absorption. Coming down to B12, again, major reason for deficiency is our vegetarian diet. Though we do have a large set of non-vegetarians as well, the intake of meats is not as high as compared to our Caucasian counterparts, for example. Coming to vitamin D3, the main reason for us being deficient, even though we are in a tropical country, is because of skin pigmentation, which sort of hinders the absorption of vitamin D3. Again, vegetarian diet exacerbates that D3 deficiency. Again, coming down to protein, though we do have a lot of protein in our diet that comes from pulses, comes from whole pulses, because of a vegetarian nature of our diet, we do not get a complete protein, and hence we always tend to lack in a few amino acids because of the diet. And until and unless our population actually learns to combine a proper cereal and pulse combination, we are going to be lacking in the complete protein. So all of these reasons that I've listed down actually shows that our population, an Indian population, is actually deficient in a lot of these nutrients, primarily because of our eating patterns, of the kind of foods that we eat on a day-to-day basis. And hence, we came out with recommendations that were primarily made for the Indian population to be able to deal with the deficiencies that come out of our population. Nutrients to stress upon here are vitamin B12, which needs to be supplemented more frequently in our patients because, again, of our diet pattern. So we have recommended that we do either intramuscular injection or we use sublingual tablets to be able to maintain B12 levels of our patients. Vitamin D3, like we mentioned, is another big nutrient. So we do also recommend that supplementation be given on a weekly basis or on a fortnightly basis, depending on the severity of D3 deficiency. And protein, again, needs to be calculated according to the ideal body weight, but also important for nutritionists in this part of the world to understand in terms of to be able to educate our patients to select a high biological value protein, and also not to shy away from also recommending protein supplementation if a patient is not able to meet its protein requirement because of the kind of diet he's taking. Also of importance here is to talk about the kind of procedures that are being done in our part of the world. So most of, say, the guidelines or the recommendations that do come out of America or Europe do talk about highly malabsorptive procedures like the BPD or the DS. However, we need to understand that in our part of the country, when we actually have, populations which are actually primarily vegetarian, we need to make sure that our procedures sort of suit this kind of diet so that our patients are able to cope up with the supplementation routine. So these are, we've just listed down recommendations for each nutrient, and you can find a copy of the paper online. But to conclude, I think every bariatric surgeon who's looking at building up a successful bariatric practice should understand that a multidisciplinary team is extremely vital for a successful practice. Nutritionists, as we realized through the presentation, are very, very important and critical to the multidisciplinary team. It is very important to understand that bariatric nutrition is quite unique from routine nutrition courses, and hence the need for specialized courses to train our younger nutritionists. Nutritionists can help in a big way to prevent complications, and can also act as a bridge gap, to bridge a gap between the surgical team and also the rest of the multidisciplinary team. And I strongly believe that given our vast cultural diversity in Asia alone, that Asians do require their own set of guidelines for our set of population, keeping in mind the kind of diet and cultural patterns that we actually have. I hope this sort of takes us to what we require in our set of the world, and we'll go back to the questions now. Thank you so much.
Thank you, Caroline. That was very comprehensive indeed. It's a very challenging topic. Actually, just to let everybody know, the set of slides are actually available under the section of handouts at the webinar. If not, it will be posted on the IFSO website at the Virtual Academy. We're actually open for questions right now, so if you could just post your questions by typing onto the questions section of the webinar, and we'll try to get through the questions together. So please feel free to post your questions right now. Well, perhaps I should start, because while the audience are getting their questions ready, I see that, Caroline, that you wrote that perhaps up to 80% of your population have protein deficiency before surgery. So that's rather challenging to meet the requirements then after surgery, and seeing that a lot of them are vegetarians. So how do you, in very simple, just in a nutshell, how do you actually then get them to concentrate on the protein intakes in particular after surgery?
Yeah, so sure. So like most of us probably do in our practice. So when we actually start off our patients on the preoperative diet and preparations for surgery, we actually start off with protein supplements from then on to sort of get them used to, taking in that kind of protein in those kind of amounts. And even post-surgery, because with vigorous follow-up, because we see our patients quite regularly post-operatively, we constantly stress on the need of prioritizing protein in their meals in addition to whatever they're getting from their supplementation. And I think a lot also depends on choosing the right kind of protein in their diet. So cereal pulse combination, for example, will help giving you a complete protein rather than having only a pulse, for example. So I think education and constant follow-up helps to sort of keep patients on track for sure.
Good, thank you. I think we have a question here. Try to see the questions right now. Sorry, this question's a little hard to. All right, let me just try to get. So I have a question which I don't seem to be able to retrieve. I'm so sorry. There's a question on.
Question.
Sorry. Sure. Go ahead, Stephanie.
Yeah, hi. I just wanted to check in terms of measurement of protein intake, how do you assess that? Is that through dietary history, or are you looking at markers nutritionally in the bloods?
So both of them actually, Stephanie. So we do have preoperative nutritional values that we actually look for before the patient actually gets in for bariatric surgery. So we definitely rely on those labs as well. And then post-operatively and pre-operatively, we do also do a 24-hour dietary call, get into a detailed understanding of their routine day-to-day intake. So I think it's a mix of both that helps us sort of determine their current protein intake. And we've also had cases when we've actually sort of deferred surgery for a couple of weeks or a couple of months if the protein intake or the levels have been, way below the mark. So that's a sort of a decision, I guess, as a nutritionist that we probably need to take once in a while.
Thank you.
Okay, I have a question that comes. What level of milligrams of thiamine, so how much supplementation of thiamine will you aim on a daily basis? Either one of you can answer the question, yeah?
Yeah.
Caroline?
Okay, so the ASMBS and the guidelines for the Indian population, we've actually mentioned in terms of severe deficiency and moderate deficiency, the kind of mg that is actually required. However, like I would say that when you're actually looking at thiamine deficiency, it's very rarely that you actually get lab reports back in time. So it's important to make sure that you supplement. You do get in India, you actually get vitamin B1 supplementation, which actually comes in, I think it's like a 1 milligram small vial that you can use either intramuscularly or through IV, and sort of supplement your patient until they've they stop symptoms of vomiting and they're actually not in that acute phase anymore. And the good thing, I guess, about thiamine is that it's water soluble, so you can sort of you're not too worried about over supplementing. So I would say that don't worry about toxicity or waiting for labs to come in, and rather if your patient is coming in persistent vomiting, just supplement and get that out of the way rather than coming back with complications.
Yeah, it's not something that we would routinely check for within our pathology requests, but only, I guess, if clinically indicated from sort of GI symptoms. But generally, what's covered in our sort of quite broad spectrum bariatric multivitamins is enough from a B vitamin point of view. So somewhere between 12 and 50 milligrams within that B complex of the thiamine.
I think there was a question also about vomiting, what the B complex vitamins given. So I think I would concur with Stephanie and Caroline that actually in most countries, the B complex actually should suffice for the thiamine levels, which is up to 50. So actually another point to make about thiamine deficiencies is that if someone is thiamine deficient and you give them very high carbohydrate diet, which can often happen in Asia after surgery, it's hard to change the diet. They might go back to the rice and the breads. This can actually accelerate the thiamine deficiency. So I think even in our country, it's very hard to measure thiamine levels, and even thiamine levels do not correlate with thiamine levels in the brain. So therefore, you can still get Wernicke's encephalopathy and neuropathy with normal thiamine levels. So the general practice is someone comes in with persistent vomiting and very poor dietary, a lot of weight loss. In fact, vomiting is the key factor in thiamine deficiency. I think we should just give IV thiamine right away for a few days and then just supplement them because the levels, like Stephanie said, will take a long time to measure, to come back, and it's not necessarily accurate. I actually have a very good question here. It's to say about zinc deficiency, which I also wanted to ask, is like, how do we test and even supplement and monitor zinc deficiency? It says that in practice, they see lots of zinc deficiency. So, one of you can take the question.
Oh, do you want to
go? Stephanie, would you like to take the question of the zinc deficiency?
Yeah, again, we don't routinely check for zinc deficiency. we would tend to do that if there are issues, say with persistent hair loss, or things that maybe patients are quite concerned about, sort of from the way they look. But it's not something that we would necessarily screen for. But I guess within sort of the dietary history, we would be checking, if adequate zinc was present, and generally if they're meeting protein requirements, they tend to be meeting the zinc requirements because a lot of it sort of overlaps.
I think that's the same that we do in our practice as well, because it's quite expensive to actually get these trace elements tested for, at least in India, so we don't routinely check for levels of zinc. However, if you do have patients who are undergone, say like a SADI or a very malascopic procedure, then we do recommend to get the zinc tested, or at least on a 6-monthly or a yearly basis. But under normal circumstances, a regular routine multivitamin supplementation in the dose for bariatric patients kind of actually takes care of the zinc requirements. At least that's what we've seen in our practice.
And other sort of manifestations of zinc deficiency might be things like pica, which is where they might be eating foods not considered normally as food. Possibly some issues with sexual performance, possible issues with wound healing complications. So not just sort of the hair loss that maybe they're initially sort of worried about, but other sort of manifestations that you need to be quite careful about and don't necessarily come up in a dietetic conversation.
Sure, actually hematological deficiencies also can be due to zinc deficiency. And then another point to note about zinc deficiency is that if you give too much zinc, you can cause copper deficiency. So if you're really going to replace the zinc, please be mindful of the copper. And actually there's a special formula that's available online. So I'm just going to tell everyone that after the webinar, if anyone has any questions for any one of us, please let us know through Manuela from IFSO. We'd be happy to address or give you some references as well. Actually, there is another question about how necessary do we think the pre-op diet is to improving patient outcomes after surgery? Any thoughts?
So we in our practice make sure that all patients undergo a minimum 7 to 10 day pre-operative diet. Our surgeons are very happy with that because we sort of just have lighter livers to deal with. However, from a nutrition perspective, we feel that it's a good sort of a testing phase for the patient to see how compliant the patient is going to be in the post-op phase. So it gives me a better judgment of the patient when I know whether they're compliant with the preoperative diet. So from a nutrition perspective, I think it makes a big difference to understand your patient psyche before surgery, to understand their compliance post-operatively. That makes a big difference to me.
Yeah, I agree. I think it's very important to show commitment to the journey. What also might improve is their diet quality when they start the pre-op diet, because from a micronutrient point of view, they are nutritionally complete, providing you're sort of meeting requirements according to BMI. So we will instigate the pre-op diet. On average, it's 2 weeks pre-op. But it's related to BMI. So if BMI is higher, we will encourage a longer time on the pre-op diet. And I think every hospital will have its own policy depending on occupational health and safety. So sometimes there might be a sort of a maximum weight depending on the sort of the operating tables that you might need to get patients down to prior to the surgery.
Good. I actually, I apologize to some of you because if your question is a bit too long, I don't seem to be able to read the entire question. So if we're not quite answering your question, please post it again. I'm going to ask a question from Mexico, actually, that if the person is, if he or she is based in Mexico, which guidelines would be more suitable for them? Would you recommend, Caroline? Yeah.
Yeah, that's a good question. So I think it's important if we don't have local guidelines to sort of see which sort of food habit and what sort of food cultures are more close to the Mexican diet, and then sort of pick out bits and pieces, I guess, from different sort of guidelines. Because if you do have a diet which is, say, mainly high in meats and non-vegetarian diet, you might probably feel that the American, European guidelines will actually work well for the Mexican population. But if you feel that your patient is somehow more sort of vegetarian in nature, then you might want to pick guidelines which are more that are catered towards the Indian population. So I think it's a mix and match of what sort of suits your patient criteria from there.
Yes, I agree. I think in Australia, in the absence of any local guidelines, we use the ASMBS guidelines, which are appropriate, obviously from the American perspective. But Australia is such a culturally diverse community that actually it may not be appropriate to use those sort of as a blanket approach, and it's quite difficult sometimes depending on sort of your client population, and if you have a mixture of cultures, you may need to sort of adapt accordingly.
Sorry, my mic's muted. What causes low homocysteine? Could high levels of B6, 12, and folate cause that?
Yeah, so they are sort of proportional. So we see a lot of high homocysteine levels in our patients because we do have very low levels of vitamin B12. So vice versa. So we do correct folic acid deficiency and B12 deficiency, and we do see homocysteine levels dropping down pretty nicely.
Right.
Yeah, I think we just, with regards to homocysteine, just that is one of the things that we do check routinely. And just making sure that, the B vitamins are all sort of adequate. So particularly with the folate, which is often low if homocysteine is an issue.
Okay. Yeah, I think homocysteine is a kind of neat thing because it's so linked to vitamin Bs, especially folate. All right, I have a question on most of the bariatric patients experience hair loss after surgery. Do you recommend multivitamins for that?
Yeah.
Yes.
Yes, we do. We recommend chewable multivitamins for the first 2 months post-operatively, or a liquid-based one. But we do advocate a lifelong multivitamin and mineral, which I guess it's difficult from a compliance point of view, but that's our current recommendation. And then if the hair loss continues sort of after a year post-op, then that's when we would possibly look at testing selenium and zinc status at that point.
I think hair loss is a rather complicated issue after surgery. It could be just the sheer fact of losing weight drastically, protein intake, iron levels, etc., zinc deficiencies as well. I guess if I think we need to be very stepwise, and definitely a nutritional diagnosis is needed by the dietitians, and if needed, we need to do more labs, like certain levels.
Yeah.
What do you think?
Yeah, we actually, so I don't know whether it's the same thing that you all experience, but we actually find that the first 4 to 6 months post-operatively is actually a period of drastic hair fall, and for precisely the reasons that you said, drastic weight loss. In our population, we find that protein intake is not as good as that time because they're still sort of struggling with the food and iron levels as well. So before we actually test for zinc and selenium, like Stephanie said, we actually make sure that these common nutrients are in line, but generally we counsel patients saying that the first 4 to 6 months they're going to experience hair fall, and then sort of follow them through for the first year, and if not, and then we take additional sort of supplementation in addition to iron and protein. Yeah.
So I guess there is also a question on do we have, sorry, I still can't get the question to be in full box. So I think Stephanie and Caroline, if you can see the full question and I'm not reading it, can you just help me supplement on that? I think there's a question on, are there any validated tools to report on outcomes post-op, particularly on quality? And that's all I can read. Can you, the very last question.
Yeah.
So sorry.
Yeah, so the question is, are there any validated tools to report on outcomes post-op, particularly quality of diet?
Okay.
Yeah, I personally am not aware of any validated tools to sort of validate the diet quality, but Stephanie, do you know of any sort of that are available?
No, no, not as far as I'm aware. I mean, possibly there are some out there, but it's something that would be really valuable to us. So if anyone wants to look into that, would be great. But generally, it's depending on the follow-up that you allow post-operatively, we work towards improving diet quality, as part of our sessions, and this can take time because you're changing habits of a lifetime. And it's a big learning curve for people who are having to sort of adapt their diet quite significantly. So I guess often these things don't happen overnight, and it does take time for people to sort of look at their diet quality, and that requires regular follow-up from the dietitian and regular pathology, because it may be that they appear not to have a great iron intake, but actually clinically they're not showing any signs of deficiency, and so therefore we may not need to be as concerned, for example.
I think there are many guidelines. Actually, the ASMBS updated guidelines for the 2017 has very, very comprehensive, extensive. I think it's a rather good guide, but then at the practical level, I think a lot of us face is that some tests are not available in certain countries, and also cost is also an issue. So yes, well, we have all these guidelines to say check copper, zinc, etc. But again, they need to be interpreted in like so many other conditions, and also the availability. So I think at the end of the day, I think someone posted a comment, said thank you for the excellent presentation, and agree that Asia, we do need our own guidelines. Especially, for example, in Singapore, we've done our studies, we have Chinese, Indians, and Malays as 3 dominant populations. So it's rather heterogeneous, and we found differences actually, just even pre-operatively among the 3, and even post-op, we've done some studies actually, not really validated, but we've actually assessed their quality, their diet post-op in terms of macro and micronutrients. While they're not very stark differences, but again, because there's a lot of culture, well, these patients have been operated on, but not their families. So they're eating around these people who still carrying on the same eating habits, and we have fasting month and feasting months, and in Singapore, there's just celebrations all year round because there's just so many ethnic people celebrating all year round. So it's very challenging. I think I agree. I think, let's say if there's a country that's predominantly Chinese, we can match up with each other's studies and then just do very simple tools in terms of just macronutrients and even micronutrient assessment. And if we could even have it online, and it'd be helpful for everybody. Yeah. So actually, I'm just gonna, Stephanie and Caroline, there's a question on about whether our patients accept protein supplement by Lee Pei-Fen. It's posted in there. Can you read the full question for me? I'm so sorry. It says, thanks for the talk. I have a question. It's quite in the middle. It said, I have a question that do your patients accept protein supplements, I presume?
Just looking at that.
It's posted at 6:46 p.m. presume it's whether our patients accept protein supplementation after surgery.
Sorry, I can't see that.
Okay. Yeah, I'm so sorry, I can't address that question.
I can talk generally about recommendations for protein supplementation. I think if that's helpful. I think the most important thing is that protein is provided throughout the day, not just in sort of one meal. And as Caroline explained, it's important to get a variety of protein sources throughout the day so that you're getting that full complement of amino acids. If protein supplements are indicated, which generally they are, particularly in the early stages when amounts that people can eat are quite small, then it's a good idea to explain to patients how they can, achieve that. So there are powders, there are protein waters, there are protein shakes. So there's a variety of different ways people can supplement their protein intake.
Okay, actually, Caroline, sorry, Manuela kindly posted me the questions through WhatsApp. I'm so sorry. I think there was another question about how they'd like to know the impact of standard intake of alcohol for different types of malabsorptive procedures. I mean, what is the impact of a standard intake of alcohol from the different types of malabsorptive procedures?
I think with alcohol, and this is a favorite, I think, question of all patients post bariatric surgery, because I think what's important to understand is that the metabolism of alcohol does change post bariatric surgery. So what we actually ask our patients to do is kind of sort of refrain or reduce the intake of alcohol at least for the first 6 to 8 months immediately post-operatively, and also educate them as to how your body sort of accepts alcohol much more differently post-bariatric surgery. So your quantity and the level of sort of, high that you would reach with the quantity of alcohol you had before surgery and after surgery would drastically change. So I think what we generally educate patients is that if you're having a glass of alcohol, then to immediately sort of rehydrate with a glass of water post-operatively to prevent to prevent dehydration, and also to be aware of dumping and hypoglycemia, because alcohol is basically just full of sugar. So I think those dehydration, dumping, and hypoglycemia should be emphasized to our post-bariatric patients.
Okay.
Yeah, so we would often explain to them also about how it's important to have something to eat, then wait the half an hour, and then have the alcohol just to help in terms of slowing down absorption. But it, as we all know, fluids will exit the gut quicker post-bariatric surgery, and alcohol, being a small molecule, is easily absorbed. So generally, their reaction is more significant after the surgery. So particularly, it's important also to mention about things like beer, which they may not be able to tolerate because of it's carbonated, and so they might need to change their choice of alcohol as well, and also just to allow the 6 weeks minimum post-op healing process before they even think about having a drink. So
okay, I'm going to just take one last question now. There's a question of, do we ever find that liver enzymes arise during the post-op weight loss, even when the dietary intake looks relatively sound? Do we see rise in liver enzymes even when the diet is relatively sound?
I think to answer that question, and this is not nutrition based, but there is an incidence of occurrence of gallbladder stones post-bariatric surgery because of excess weight loss, and that could probably show a rise in your liver enzymes. Other than that, unless a patient has had a pre-existing liver condition before bariatric surgery, I'm not really seeing that if sort of dietary intake is good. Yes, if you've had malabsorptive procedures and a patient's protein intake has been compromised, then of course yes, but not under general circumstances. So if you do see liver enzymes, I think probably just do a sonography, check for gallbladder stones, if everything else is in place.
I think it has been reported before, not fully subscribed to, but sometimes if there's very rapid weight loss, fat doesn't dissolve. So the triglycerides in the fat and in our fat, as with visceral fat, need to go somewhere. And the often site is actually, and then sometimes people lose muscle too. So again, your muscle storage is low. There's an influx of the TGs or triglycerides into the liver. And sometimes that can cause a mild or a steatohepatitis for a transient period of time. We've seen a few cases ourselves, and it can be rather high at times. Monitoring and ensuring there are no other secondary causes of hepatitis, and sometimes we had to refer to our hepatologist for even liver biopsy. So again, the physical structural causes have to be ruled out first before we think about this. And usually they improve over time. Sometimes it may take even a year to completely resolve. Yeah. All right. I think in the interest of time, I'm just going to end the webinar now. I think it's been very, very exciting first integrated health webinar, and very interactive. So I'd like to thank Caroline for the wonderful talk, and Stephanie for your insight into all this. And again, we hope to see all of you at the IFSO APC in Guangzhou in a few weeks. I've got a note from the organizer, Yang, that he hopes to see all of you there in Guangzhou soon. So keep well. Good afternoon, good evening, and good night to everyone. Hope to see you in Guangzhou.
Thank you so much. Thanks. Bye-bye.
Thank you. Thank you.